Hi, welcome everyone. I'm Dominicus Wong, family doctor, and I'd like to introduce Fiona Cullen, our executive director from the Burnaby Division of Family Practice. Hi,
Hi.
Leona.
Hi, nice to see everybody. We have folks coming in the room. Happy to see you if you've been here before. It's nice to have you back. If you're new, welcome.
Yeah, and as you're coming in, you can this little picture in the bottom corner of the screen is actually what my medical office assistant Christina and my medical office assistant Helen, who is also my niece on Fridays, in case any of my patients are there, be extra nice to my niece. Don't yell at her. She's really sweet and she's planning to go into nursing. But this is what they see and you don't see behind the counter. So it's our kind of the motto for our practice. Treat every patient like a best friend or a family member. So that's how we know that we're being as patient as we can be and making sure we're putting the same thought and effort into your problems and making sure that we meet your needs. So that's our secret motto. So you got the inside look of Christina and Helen's death. And this talk is from both sides of that important relationship you have with your doctor and any other healthcare provider that you're working with. So you can see things from their point of view. But the most important thing for my purpose today is so that you know how doctors and nurses think and how to make sure they have everything in mind. So they treat you like a family member or best friend so that they put that extra thought into your problem and help you achieve your goals. Because when I was in medical school, there was such a thing as doctor's orders. And we thought that if we ask a patient to do something like exercise more, take these medications, go for this test, that the patient will do it. And when they come back, we used to use a really bad word called non-compliant for the patient that didn't take their medications or follow their diet or exercise or quit smoking. But after medical school, I had further training on how to communicate better with patients. And it wasn't mandated by the college, this was voluntary. But I wanted to know more about how to improve the outcomes for my patients. So my patients with diabetes wouldn't get all the complications, like problems with their eyes or with their kidneys. And the problem that most of us do as doctors is that we give the best advice, we give the scientific rationale why you should do these things, but we don't always listen to what the patient's priorities are. So family doctor, it's a lot easier because we get to know our patients over time personally. And we do need to listen for what your priorities are and to make sure that the goal we set is actually your goal and not just my goal or the doctor's goal. Because of course you want to do what's healthy for you, but you could be struggling with things at work, or you have another medical concern, or some stress at home, or relationship things that are more pressing at that time. So all doctors and nurses are here to help and support you, but there's ways that we can do it better. And there's some tips in this talk. So even if you don't have a family doctor, or if you're at a walk-in clinic or the emergency, there's some key things that can help you have a better visit and get the information you need and make sure the doctor has the information he or she needs to give you the best care. So making most of every medical visit, be it with your family doctor or a walk-in clinic or the urgent care clinic for an emergency or an unexpected visit in another province or country. Well, Leona, were there any announcements from the Burnaby division that you needed to share?
Sure, yeah. Before you get started, that would be great. I just wanted to share our division is very, very busy. We have a lot of activity going on that's relevant to you, including our Empowering Patients page. I'm pleased to say that our schedule till April is now up on our website, so I will share that link with you in the chat. Keep an eye open for that. There's also a link to the other resources page, which is another Empowering Patients page, and that includes all of Dr. Wong's presentations and key points documents, so information pages on each of our topics. So check that out. This presentation is already up there on the site, so you can check it out. You can print it. You can share it with friends. By all means, it's there for everyone. And we also have a page on if you're looking for a family doctor. So it's got all the information on what you need to do to register on the Health Connect registry, the provincial wait list, and our patient attachment coordinators, of which there's one online today. Masood, thank you for joining us tonight. So our patient attachment team will, when your name comes up on the list, they will get in touch with you and get you matched to a family doctor or a nurse practitioner. I'll also pop the Primary Care Networks or PCN page, website on web link into the chat. And that's all of the community supports that the Burnaby Division, the Health Authority, and our community partners have worked together to build. So we have senior supports, we have community supports, we've got the Burnaby Community Fridge, for example. There's fridges out in the community that help with people that are hungry, or if you have food to donate. Those types of things that are happening in Burnaby, and you may not know about them. Also, another initiative that happens under the PCN umbrella are Doc Talks. So other doctors in Burnaby come together and they put information sessions similar to this out there, and recordings of those are on the page I'll put in the chat. And lastly, we've got our monthly checkup newsletter, which is vetted news and information on health and wellness, some of it in Burnaby, some of it a bit broader. So if you'd like to subscribe to that, I'll put a link in the chat and you can subscribe. They come out once a month. The October 11th issue is there, and we'll be putting one out in November and December. So that's it. I'll start putting some links.
Great. Thanks,
Thanks,
Leona.
Dr.
And so you can see that the Burnaby Division of Family Practice is very busy. And the Burnaby Division is a nonprofit association. Leona is the executive director. But the members of the Burnaby Division are the family doctors that serve the Burnaby community. So there's loads of useful things and resources, as Leona has alluded to. So take a look at our website. So why are we here? We're here because as family doctors, we're part of a circle of caring. So I care for my patients, and I also care for my community because I grew up in Burnaby. So this is my way of giving back to the community. And I'll share a little story later of why I became a doctor, but also because of Burnaby Hospital and the kind doctors and nurses that looked after me there. And we're all here because of the future. We're looking after your health, and we hope that you can share whatever you find is useful information that you can share with your loved ones and your friends. We care about our patients and we care about our community. And when we think about healthcare, most people think about the work of doctors, nurses, and other allied healthcare providers in or out of the hospital or the clinics. But really, most of the care that you get is in the community, not so much in the hospital. But who is the most important person? Who provides most of your healthcare? And it's not me, your family doctor, it's actually you. But it's so important that we empower you to give you the information you need and to provide you access to the help you need to. And that's why family docs are so important, as being your advocates for your overall health and connecting you with the healthcare system. So the best predictor of your future health are the habits you practice today, at least those things that are within our circle of influence personally. And real healthcare is the self-care. We're here to empower you with that. And in all of our talks, the 4 foundations of caring for ourselves are what you put into your body, what you eat, what you do, physical activity and rest, how you feel, emotional well-being, and how you connect, healthy relationships. And for you to be an empowered patient, you need support for that good self-care. Healthy lifestyles, managing health conditions, getting the care you need. That's the information that I try to provide, and Leona is supporting us through the Empowering Patients program. You need support to achieve your personal goals, and we need to improve patient-doctor communication. So there are so many varieties of the patient-doctor relationship, just because all of you are unique, and all doctors are quite unique as well. And all doctors have one common calling, which is your well-being. Just a little short while ago, just last month, I started teaching seminars again for this year with first-year medical students. So as an icebreaker, we went around the table and I asked each of the 8 students to share why they chose medicine. And it was quite inspiring, their origin stories about how some of them dealt with illness in the past and their interactions with doctors and nurses. Others were advocates for their family members. And they had positive and negative experiences too. But I asked them to remember the reason why they go into medicine so that they continue to find meaning in the stressful part of their schooling as well as in practice as well. So that we're all in touch with that deep focus we have on improving the well-being of the people that we can touch and look after. So as I mentioned, doctors are people too. We're all imperfect and we all have our own quirks, and you probably met a few quacks as well. But we're all different, but we all care in our own special ways. And of course, we get stressed. You've heard a lot about physician and healthcare burnout. So many causes. It's really hard to stay on time. Sometimes patients are angry. Not too many of my patients because we're kind of gotten used to each other. And some cases are really complex, not due to the patient's fault, but people can be really, really sick and they take priority and it takes much more time. And of course, we all have personal issues like with staffing, relationships in the office, although at Prime Care, we're all one big happy family. And there's a lot of work that healthcare providers do behind the scenes. Uh, our former executive director would talk about back of house, all the things that you don't see, like in a restaurant back of house is that crazy stuff that goes on those dramas you see about what's going on in the kitchen, but running behind the scenes, the things you don't see when you're in the front of the restaurant. So there's so much that we do behind the scenes that consumes a huge amount of our time. And for me, it's completing a variety of forms to get approval for certain medications or treatment, to do a referral to a specific type of service that's in the community, writing letters for patients for work or medical legal letters, applying for the coverage of certain drugs because we have pharmacare special authority where we actually have to go through the history and say why this more expensive drug should be taken rather than these less expensive medications, and we have to document particular criteria for each patient. And all you might see is that the pharmacist says I need to get some special authorization to get this drug, and then we're up late at night trying to go through your record to get that approval done. Reviewing test results is kind of exploded since I started practice. So when I started practice 30 years ago, it would take me like 30 minutes at the office with these paper lab X-ray results and consult reports that come to my office. And then I simply have to kind of go through them, highlight things, check a few things for follow-up, then file them into the paper charts. But now with our electronic medical records, which are really good in many ways for communication and for follow-up and to make sure things are not missed, but we actually get a lot more versions of tasks. The average is about 200 a day for me, 200 little tasks that I have to kind of go through that can vary from letters from a consultant or some forms or lab results or X-ray results. And I can't simply sign it off. I actually have to type in a summary and then put that into the patient's electronic chart. It's not automatic. We actually have to dictate or write out consultation letters every time we do a referral. And we do a lot of follow-up with patients as well, like calling up on patients on urgent results and lab results as well. And doctors take call. Some specialists just sign off their phone and say, go to emergency if you have any problem. But for family doctors, we have to take turns being on call for our call group for our office. So my office has 12 physicians. So at least we don't have to be on call every night, like when I was in solo practice. But we do have to take call for anyone in our group to deal with urgent things that come up after hours and on the weekends. So things that are going on after you leave the office. So that non-face-to-face, what we call the administrative burden of medicine has really exploded, and it's contributed a bit to the burnout in a lot of physicians, including family physicians. It's estimated it could be varies from 20, 40, 50% of our work weeks. So even though we may be in the office 5 days out of the week for 10 hours, there's another 20 hours that we're spending when we get back home or during our lunch breaks, but often on the weekends. I spend a lot of time on the computer and with a pile of those paper forms. We'll never have a paperless office because patients keep bringing in paper forms. But to help me get through those things that are not so much fun, I love the face-to-face time, but the non-face-to-face time is a bit tiring. So it's helpful, as I mentioned to my medical students, to remember why we became doctors and why particularly I became a family physician. So when I was 10 years old, I had rheumatoid arthritis, a very strange one because there was a lot of non-joint related symptoms, including rashes, fevers. So I had a particular flare-up with full body pain, fevers, and a rash, and had to be hospitalized for 2 weeks at Burnaby Hospital on the pediatric ward. And it was a scary time, as it is for anyone that has to go to the hospital, especially when it's not really clear what's going on, or if you're going to get better, or what you're going to need to get better, or what tests you have to do. But I had great comfort in the care I received by the nurses and the doctors because they were treating the kids, not the disease. And I knew I wanted to do something like that to gain that knowledge and skill and that interpersonal skill so that I can be professional, but treat the human being. So we don't go into medicine to treat disease or to treat a part of the body, we treat the whole person. And we only see disease or conditions in the context of that individual person's life. And I chose family medicine after considering psychiatry and pediatrics and obstetrics. I did an internship that's called a rotating internship that we do with people that are planning to be surgeons, family doctors, or pediatricians. We all are together and rotate through all the specialties. And then at the end of that, we can decide which path we'll follow. And anyone after completing the rotating internship, it was able at that time to do locum work as a family physician in the community and then decide to go into a specific residency to do more training in another specialty. But when I actually got to work in family practice offices, I was really entranced by the stories the patients shared and how important the role of the family doctor is in the stories of all those patients and their families. And that we can positively be a part of and influence the stories that patients tell of their lives and their experience with the healthcare system. And I already gave you this behind the scenes look. This is our practice model. So this is the side of the medical office assistant's desk, Christina and Helen's desk. This is the part where they're looking out towards you when they open the windows. My patients don't see this, but my staff remembers that we treat every patient as a friend or a family member with the same degree of care and concern. So give them the same specialist and treat them the way that we would want our loved ones and ourselves to be treated. As I mentioned in family practice, we don't treat disease, we care for the whole person. And I think family practice is unique among specialties because we treat the whole person and not just the individual conditions or parts. Now, of course, there's some fantastic specialists out there that do treat the whole person. And I've been lucky to meet a large number of specialists that have a similar point of view too. And as a family physician, we are your advocates to help you meet the challenges of your life and help you get through this complicated healthcare system and get the care that you need as best we can. You've heard that primary care or family practice is longitudinal. That means we get to know you over time, over multiple visits. And with time, you get to know most of the family as well. But my take on family practice that it's more than longitudinal, that it's latitudinal as well, because it has breadth and it has depth. And that depth is our care is really informed by your, as a patient's experience. And the breadth is that we understand the context of your whole life, at least those things that you share with us. And people are more forthcoming with their family physician that they've known for years than to doctors they just met for 1 or 2 times. And of course, we build trust over the long term, over a lifetime. And that trust goes both ways, that I have faith in my patients telling me and sharing the most important things that I need to know to care for them and to share what their priorities are. And again, we empower our patients to be agents of positive change in their own lives, to help them transform many problems into important goals. So as we know, the pandemic has really transformed the patient-doctor relationship because many doctors and a lot of our work is now not always face-to-face and in person. There's a lot of my patients that I haven't seen for over a year or several years. And we all surprise each other when we take off the mask and see how much older we both become. So phone and video visits, they are still a major part of care, even though the pandemic has settled down a bit. But you know, COVID is still out there, so make sure you're getting your immunizations. And we're giving them in the family practice office as well. So you can get the most updated COVID booster shots, most updated ones to cover the latest variants, not only with the pharmacies, but also your family doctor's office, along with the flu shots. And COVID is still out there. So if you haven't had COVID or been immunized, be very careful and don't mistake something for just being a simple virus or flu. And of course, we've been overloaded with information, and a lot of people rely on the family doctor to help them decide what to do about vaccinations and mask wearing. So challenges we face in the patient-doctor relationship. So I'll be talking about each of these: access, finding a family doctor, waiting for an appointment, the problem with time, so many problems and so little time, and the language that we communicate with, because often we are trained in medical school to learn enough words to constitute a whole new language, and we need to translate that into plain English and to speak in the language of our patients. And finally, that difference between doctor's orders and the patient's goals. So let's start with access. Finding a family doctor, waiting for an appointment. So as Leona has mentioned, on the links and on the division website, you can find information if you don't have a family doctor. I believe 1 in 5 people in BC and Canada do not have a family doctor. So all the family doctors in the community, pretty well all of them, are working with the provincial government in sending in a list of which patients are attached to their practice and which doctors and practices have the capacity to take on new patients. So by community, if you register with HealthLink BC on the Health Connect registry, if you don't have a family doctor in your community that you would need to get your care, then you can get on the list. And people are actively trying to match people up with the list. So the situation in Burnaby has actually improved because of this system and because transformation in how family doctors are being valued. So now for the first time over the past 2 years, a lot of that after hours administrative work for our patients of our family practices, we're getting paid to actually spend that time reviewing lab results and writing those referral letters and doing all the extra things to give you care behind the scenes. So that's a big change. And it's attracted a lot of young family practice residents to go into community care. So I'm lucky to have one of those keen young doctors that is working in my office as well and sharing care with some of my patients during the week as well. So that's a positive thing. So in BC, unlike other provinces, more doctors are turning to community family practice again. So we're able to get doctors to cover for us on holidays and to join us in our practices. Why is there always a wait at the doctor's office? Well, we don't intend it to be a wait. Although I know of one colleague who is always behind 2 hours because she goes to her office, starts 2 hours late. But most doctors start on time. The reasons for the wait are multiple. Patients are coming in family practice more than anything else with multiple problems, sometimes multiple complex problems. So they may come with 1 or 2 presenting problems, but actually have more complex things going on. And we are interrupted constantly during the day. It's hard to stay on task when we're getting calls from the emergency or have to refer a patient to the emergency department and be on hold to speak to the emergency doctor, or if we're looking after a patient in a hospice or in a nursing home, and we're getting some urgent calls from the nurse that we need to attend to right away. And frequently we get calls also from the pharmacies. And sometimes the patient may come in for another visit, but something unexpected has happened. A loved one has died, and we need to take the time. It's something that can't be done in just 30 minutes, that they need the time for us to counsel them and support them at this time. So these things happen pretty well every day. And the nature of our work, we're all human beings. Every one of our patients and doctors too, and health and disease are infinitely complex and so dynamic and often unpredictable. But there are things that we have control over. So the list is a 4-letter word to a lot of my colleagues, but the list is, well, if you're married, it's something your spouse gives you. If you're a doctor, it's something the patient brings in, either written or it's in the back of their mind. So with every problem on your list, or every symptom that you bring to your doctor is going through a mental process through our training. We need to listen carefully, because you've kind of prepared a story about how your symptoms started and what you think is going on and how things have evolved. And we have to ask appropriate questions for that condition. And of course, document every detail and answer that in the chart. We used to do it on paper, but now we're doing it in the computer at the same time. And for every problem or concern, we have to do an appropriate physical examination. Hard to do by video or telephone. That's why some of the things we discuss on the phone ends up needing to bring the patient in and do a physical examination. So we do an appropriate physical examination for that condition, so we can assess for relevant positive and negative findings that can help us determine what the diagnosis is. So we need to take time to work through this diagnostic mental process. And while we're doing that, we're formulating what we call a differential diagnosis. So there's the most likely diagnosis, but there are also many other possibilities for symptoms to appear in a certain sequence or certain findings to be apparent. So we're trained to recognize the common presentations of different conditions, but also to keep in the back of the mind, it could be something else. It could be something that could be more serious rather than the obvious. And then once we arrive at a diagnosis or several possible diagnoses, we'll formulate and communicate to you a plan for further investigation or for managing that condition. And I'll talk about the process of how we talk about risks and benefits and informed consent for those investigations and treatments. And of course, we have to translate our medical thinking into plain English so that the non-medical person can understand, because it's important for that mutual understanding of your condition or possible conditions and how we're going to manage it for you to give full consent, which is one of the cornerstones of Western medical ethics. So because every problem and symptom you bring to the doctor, your doctor is spending even more time after you leave the clinic, that behind the scenes, back of house work that we do. We need to find the most appropriate specialist for that referral. So we have a network called Pathways, where we can look up an appropriate specialist for a community, for a condition, and it kind of lists what each of those specialists does. Unlike a family doctor, specialists can say, I only treat these types of conditions within my specialty. Like an ear, nose, throat specialist might focus on sinuses. Another one will deal only with ears, and some will deal with all ear, nose, throat concerns. But many specialists subspecialize in that way and only treat certain conditions. So we try to find the perfect match, and then we write a referral letter and include all the relevant investigations from your medical chart. And then we have that sent over to the specialist, and our medical office assistants will follow up with phone calls. And it's a little bit different for each specialist how they like to receive the referrals. Some of them get back to us right away, and some of them, it's a black box, and we have to follow up with them repeatedly to find out if they've given us an appointment. And some specialties like neurosurgery could be a crazy long wait, like 1.5 to 2 years for spinal surgery, just for a consultation. But oftentimes we'll get a rejection from a specialist, even after we've looked at all the criteria and thought we have matched things appropriately according to the Pathways Network. And then we have to search for another specialist. Or we set up the appointment and then the patient checks great MDs and doesn't like the comments on that particular specialist. And then we go on another search to find another specialist for that same referral. So it is not a simple process. A lot of the referral forms are quite detailed. They're not all generic. And of course, we're spending a lot of time writing notes for work, for insurance companies, sending letters, disability forms, getting authorization for medications from pharmacare as well as from extended medical plans like Blue Cross. And we spend a lot of time sending prescriptions to the pharmacy. So every prescription that you request, you might tell a receptionist, but I actually have to go into your chart, check that your condition is stable. For example, if it's high blood pressure medication, to make sure we've checked your blood pressure, that it has been stable, that we don't need to review that medication. And some of the things require us to make sure that we've done appropriate tests for monitoring, for example, with diabetes medications and cardiac medications. We're completing a lot of lab requisitions that we're sending out to patients since we're doing a lot of things virtually as well. And of course, we need to make sure that visit note is very complete, that it contains a history of every symptom, that we've asked the relevant questions, that we've come up with a differential diagnosis, that if it requires a physical examination, that we have noted in the chart what are the relevant positive and negative findings in our physical examination. And it has to list what our plan is. So that each visit note should be clear so that if I was disabled or not coming into the office, someone was filling in for me, they could clearly see how the doctor was thinking, what the plan was for that patient. There's very high standards that we have with the College of Physicians and Surgeons. That college is the regulatory body for all physicians in our province. And their mandate is to protect the public, to protect the patients. So we need these high standards for medical records and medical practice. The other thing I do as a family doctor is I go through your chart every time you come in, and periodically, even when you don't come in, to ensure that you're up to date for appropriate screening tests according to your age, gender, and your family history. And if you have a chronic condition, we're making sure that the relevant tests, such as the diabetes blood tests, are up to date. So these processes take a lot of time and a lot of mental effort. We actually get a lot of decision fatigue as the day progresses and into the night and into the weekends. So you can imagine what it's like to manage multiple, often complex problems in one visit. Your doctor requires a lot more time, so it's not necessarily a simple thing when you add 2 or 3 things onto the 3 things that you were coming in for. So please don't save up multiple complex problems over the course of a whole year and expect the family doctor to manage all of them in one visit. So this is not an exaggeration. Here's an example. A patient may come in with a chronic cough, but also weight loss. They have diabetes, although that's not their primary concern, and high cholesterol and high blood pressure, and are wondering what screening tests they do. And in addition, they're starting to get headaches. And this could be a patient that hasn't been in for a year or a year and a half for some reason, and they want to catch up all at once. So it is important you share all your concerns with the staff and the doctor, but not expecting everything to be done in one visit. Of course, we can manage more than 1 or 2 things at one visit, but we want to make sure that the doctor is not trying to rush through the problem and not thinking it through, because that's where we can make mistakes with decision fatigue. And be very careful about, the worst thing is when we get surprised when the visit is done, when we've dealt with 3 to 5 problems, and then at the very end, the patient says, by the way, I've been getting this chest pressure. And as you might suspect, chest pressure could be a variety of things, but could be a cardiac condition that we need to deal with right there and then. And that's one of the reasons we might end up running an hour behind in the office, because we had to deal with this surprise symptom of chest pressure that was added on at the end of a complex visit. Or when you ask for something that seems quite simple, like to look at a mole or a lump, because that we also need to examine it carefully and write those details in the chart and take a history of how long it's been there. And if you allow us just to rush our way through it, the doctor may not have time to document. If that happens, then we don't have anything for comparison. So that's why things get misdiagnosed if something is added on that seems like a simple thing, but could be serious, like a tumor or cancer. So a few minority of my patients might think they're saving the healthcare system by saving up all their problems, but you're actually forcing the family doctor to kind of rush through the problems, and we might make a mistake. And that's one of the worst things we can do as physicians. This is like a poster that we have in the office that we open up on our computers. So one of my associates and colleagues at work, we share this picture when we're feeling that way. So do share the list. So when you talk to the medical offices and booking the appointment, let them know all your concerns. And he or she will let you know if this might require more than one visit. And if things have changed, to share that when you arrive at the office so that the doctor can be aware of it as well. So what you can do to prepare for your medical visit is definitely bring your list of your concerns, share it with the staff when you make the appointment, review it at the beginning of the visit with the doctor, and don't forget to bring a pen and paper so you can take notes. I usually keep a little pad of paper in the exam room because I do like to write some things down for my patients as well, especially some of those complex medical terms, or if we have a complex plan of things that we're doing, to kind of make a list for the patient too. So we like lists as well. Now, on to the challenge of medical language. So even if we're trying to speak plain English, it's important that we're explaining things and taking the time to explain it so that you understand. So don't hesitate if you don't understand to ask the doctor to explain it if you don't understand. And people are really polite and they might pretend to understand, like you might be if you're in a foreign country. But we need reminders if we're not communicating well to explain things clearly. And if there's a complex plan, to write it down, or medical terminology, don't hesitate to ask us to write it down. Better yet, with some doctors writing, maybe ask us to print it, or print it again if you still can't read it. Now, these are important things that you should know about anything that a doctor recommends for you. That could be a treatment, it could be a prescription that we're writing for you, or it could be an investigation like a CT or an MRI or a colonoscopy. Number one is indication. That's a medical term for what is the reason for that test, investigation, treatment, or prescription. So what condition is it treating? Like this medication is for high blood pressure or for managing your blood sugars or for your cholesterol. What are the common risks or side effects of what you're proposing? For example, one investigation for rectal bleeding is a colonoscopy, where a specialist will give you some sedation and in the hospital put in a flexible scope through the anus up into the large intestine. And it's looking for causes for bleeding, including polyps or tumors, or an inflammatory condition like inflammatory bowel disease or Crohn's disease. So that's the indication or reason, but the common risks are, or side effects are, the preparation that you need to take to empty the bowels, which causes lots of watery diarrhea, so that there's no poop in the bowels, so the doctor gets a good view of the whole colon. But there's also the risk of the sedation, and making you too sleepy or making you feel nauseous. The major risk of the procedure, like the colonoscopy, could be perforation of the bowel and infection, which could be life-threatening. And of course, there's always alternatives. There are recommendations. So if I really strongly feel the patient does need a colonoscopy, I'll tell them that's what I would recommend for my mother or father or child or spouse with with your condition, but to know that there are alternatives. What are the alternatives to taking the blood pressure medication, or are there different types of medication that you can take? So the reason for what's recommended, the common risks or side effects, the major risks or side effects you'd like to know about, and what are the alternatives. So those are the 4 things you should know about any treatment, investigation, or prescription. So specifically for every drug that you're prescribed, you need to know what it's for. So you're not being impolite by asking, what is this medication actually doing and what condition is it treating? You need to know if it's going to interact with any other medications you might be taking, including vitamins or over-the-counter medications or some foods. You need to know the 2 names for the drug. There might be a brand name and there may be the generic name. And you need to know the dose and the frequency. So I'll give an example. So there is a cholesterol-lowering medication called Lipitor or atorvastatin, and it's for lowering cholesterol, specifically LDL cholesterol, which has been associated with hardening of the arteries or cholesterol deposits in the arteries. Its possible interactions is that it could interact with a variety of medications because it's metabolized by certain enzymes in the liver. And it also interacts with grapefruit juice. So drinking grapefruit juice at the same time as taking this particular medication might raise the levels of the drug and cause effects on the liver. The brand name is Lipitor, Lipitor, and that's kind of like a given name. And it's when a drug first comes out, it's research, and the patent belongs to a drug company, and that drug company, after a number of years, other companies are allowed to make generic versions using the same molecule. So the generic name is just the name of the molecule, the chemical name of the molecule, atorvastatin, and Lipitor is the brand name. So if it's a brand name drug, then you should know that name, but you should also know the generic name. So both should be indicated on your prescription. A lot of generic drug companies, like Apotex, have a prefix APO. So if you see APO slash, what comes after the slash is actually the name of the drug. So it's not enough just to remember your drug that you're taking as APO, or MINT, M-I-N-T, is another generic drug company prefix. So the prefixes aren't too helpful for you because they just tell you you have some drug from a generic drug company. When I first saw that MINT prefix, I thought, oh, they make a mint flavored version of that drug, but it actually turned out to be a generic drug company. So try to learn the whole names. And if it's not clear, just ask your pharmacist or your family doctor to clarify. We need to know the dose or the milligram size. So not just one pill, because pills come in different milligram sizes, and how you're taking it, the frequency. Is it taken 3 times a day with meals? Is it taken twice a day? Is it taken in the morning or just at bedtime? So the 4 things you should know about drugs. Those last 2 are really important so that if you are going to the emergency or walk-in clinic, you'll be able to show them the list of your medications that indicate what the drug is, the dose you're taking, and how frequently you're taking it, and what it's for. Now, these are 3 awakening questions. So, because doctors can be rushed, not necessarily because you bring in a lot of problems, but sometimes you're in a walk-in clinic, they're in a rush, there's a long lineup. The doctor could be rushing and not thinking of you as a family member or friend. So it's easy to rush and jump to the obvious diagnosis. But it's really important. If you have a feeling or you just want to be on the safe side and make sure the doctor hasn't jumped to a conclusion, please ask one of these 3 questions or all 3 of them. Doctor, what else could it be? So that makes us think back, well, this is the diagnosis I gave, but yeah, did I narrow my funnel of differential diagnosis too quickly? Could it be something else? And the second question asks, what is the worst thing it could be? Because that's how we're trained. We're thinking about what could be the worst thing this could be? Like, could this be life-threatening? Could this be cancer? So we need to know that the patient's symptoms and the history are not an unusual presentation for something that could be much more serious. And then finally, what would you recommend for your mother or father? So if you ask the doctor that, then they'll think of their mother or father or their sibling or their best friend, and realize that you are the best friend, child, or parent of someone that holds you really dear, and you deserve that same degree of consideration. So again, that's the motto for our office, but it's a helpful reminder if you're concerned that the doc might be rushing into his plan or his diagnosis. So these things are really important to all healthcare providers. And I'll give an example kind of related to a colonoscopy. So about 20 years ago, I have a patient that she's close to 80 now, but she's alive today because I thought of these questions. She had a sore throat. She had come in for a second opinion because she was just in the emergency last night with a sore throat, the previous night with a sore throat. I asked her for a little bit of history, and she said her throat felt she felt a bit unwell immediately after a colonoscopy um, at another hospital with a specialist I don't refer to. And this is um, a long time ago, about 20 years ago. She had mentioned it to the nurse, and the nurse said, "Oh, you're probably just coming down with a bit of a cold. Go see your doctor if it persists." So later that evening, she went to the emergency because the sore throat was a lot worse, and she felt a little bit short of breath as well. And I saw her the following morning, and I knew that she had just had a colonoscopy. And the simple thing, the emergency doctor thought that she just had a virus and possibly a strep throat and gave her some antibiotics, because that would be the obvious thing. But when I saw her, I realized the worst thing could be a complication from her colonoscopy, especially when she started getting symptoms soon after the colonoscopy. So I took the time to examine her carefully, and it wasn't the inside of her throat that was sore, it was the outside of her throat. And when I felt carefully on the outside of her throat, I felt some swelling and some crackling, like Rice Krispies. And I recognize that as a rare symptom of subcutaneous emphysema, which is air that's trapped underneath the skin. And one possible cause could have been from a colonoscopy. If it had perforated the bowel, it could cause the release of gas or air. So that was subcutaneous emphysema as a complication of a perforation of her bowel. So I immediately sent her to the emergency and spoke to the surgeon on call. She had a partial bowel resection from the perforation and survived and remains very healthy today. But that's because we thought of what else it could be and what's the worst thing it could be. And those are useful questions that a good doctor always asks himself. But if you think we're in a rush, please ask us these questions. What else could it be? What's the worst thing it could be? And what would you recommend for your mom or dad? And the final challenge is those old doctor's orders that I mentioned at the beginning is we don't give orders anymore because no one's going to follow them. So we need to listen to your goals. So what are your most important goals? And so tips for any of us for setting our own goals is to choose a goal that matters to you. Because if your spouse, your roommate, your parents, or your kids have a particular goal for you, it may not be what you want to do. Likewise with the doctor. So choose a goal that matters to you. Visualize yourself achieving that goal. So that kind of programs your subconscious and primes you for success. But break down that big goal into a little goal. So if your goal is to start exercising, then you're not going to start running 5 kilometers tomorrow. You'll start with a little bit of walking for a few minutes every day, or maybe every other day. And once you've achieved that smaller goal, then you can ramp it up a little bit with your renewed confidence and your renewed skill and fitness. And then eventually you may be able to do the sun run if you take your time. But other keys are to write down what your goals are, because that's just simply writing it down and sharing with somebody else. It goes a great way for you to actually accomplish that goal. And you may have heard of SMART goals. So it's more than just being healthier. What specifically do you want to do? How much and how long are you going to be doing that? If it's going to be exercising or walking. And it has to be achievable, not going out and running when you haven't even been going for walks, but starting with shorter walks. It has to be relevant. It has to be important to you and your health or your well-being. And it has to be related to time. When are you going to do it? How often are you going to do it? And when are you going to evaluate things? And what are you going to do to step forward to build up upon that successful goal? And who are you going to share your success with and invite and share to improve your lifestyle? And of course, we have to anticipate and prepare for roadblocks to whatever your goal might be that getting more exercise. An example would be if you're planning to go for more walks, you can't just leave it for the sunny days, especially in Vancouver. So what are you going to do when it's raining? And will it be walking indoors? Will it be doing some other exercise? Or would it be just wearing bright colors and wearing rain boots and carrying an umbrella? And again, enlist the support of people around you, neighbors, people in the house, and your family doctor if you need some help in achieving your goals. So we always start with the patient's goals. So if you have a goal, don't hesitate to connect with your family doctor. Burnaby family doctors also have access to refer their patients to coaches, to healthy lifestyle coaches. So if you want to improve your health, we actually have coaches that we've hired through the Division of Family Practice and the primary care networks that can help you achieve your goals of a healthier lifestyle, improving your diet or improving your fitness level. So these are some key things that you should know about your medical history. They should be at your fingertips. Most of it could fit on one page. And it's important for you to always have on hand when you're traveling or in case of any emergencies where you might end up going to the emergency department. So all family doctors have this type of summary in your chart. So if you need some of this information, don't hesitate to reach out to your family doctor's office. So you should know or have in your fingertips any allergies you might have to foods or to any medications and what reactions you had to each of those allergens. Any healthcare provider should know about your family history, like history of premature heart disease before the age of 65, history of particular cancers like colon cancer or breast cancer, or a history of other conditions such as diabetes, because they could be relevant to your presentation and your current health. You should have a list of any major hospitalizations and operations you have. Some people don't know the medical terminology for their procedures, like a laparoscopic cholecystectomy, which is a gallbladder operation, or an appendectomy for removing their appendix. So you should have a list of those medical terms for those operations and major illnesses that you've had, as well as any chronic medical conditions such as high blood pressure, diabetes, coronary artery disease, such as angina, or other types of conditions like heart failure. And you should have that list of medications, again, with those key things that you should know about the medications, the reason for the medication, its indication, the generic name or the name brand, the milligram dose, the frequency that you're taking them. If you don't have a family doctor, in addition to those key questions that you should ask and the key things you should know about every medication and a summary of your personal medical history, you should be aware of screening tests. What do you need to get done? So the 20% of people that don't have a family doctor don't have the opportunity for the family doctor to review their chart and remind them. But we all need screening tests at different ages, depending on our genders. So screening tests are for the early detection of medical conditions with people with average risk and that have no symptoms. But if you do have the symptoms or a family history of conditions such as breast cancer or colon cancer, you might require more specific, earlier, and frequent testing. So if you're having symptoms, these don't apply to you, you should get them looked after. So one screening test most adults should have is checking their blood pressure. And this has fallen by the wayside during the pandemic because a lot of people haven't seen their own family doctor for 3 or 4 years. But we usually say about once a year you should get your blood pressure checked if you have normal blood pressure. But if you have been diagnosed with high blood pressure or hypertension, your family doctor will let you know how frequently you should be monitored. It should be, of course, at least once a year. But if your levels are up and down and not controlled, or if you've changed your medication recently, then it should be checked more frequently. Screening for cervical cancer. So traditionally, this is the Pap smear, which is done with a speculum in the doctor's office, starting at age 25, continuing to the age of 70, and usually done every 3 years if those tests are normal. We usually get a report back based on the results that tell us how frequently follow-up should be. So if there's some changes on the cells that we find on the Pap smear, it might require follow-up in 3 months or 6 months, or it might need a further investigation called a colposcopy. And in BC, we're one of the first provinces to introduce another way of screening for cervical cancer. So women who have never been screened, like never had a Pap smear, and those that have had normal Pap smears in the past 3 years, they could be eligible for self-screening. So this is actually a very simple at-home test, and the BC Cancer Agency can send eligible women the screening kit, and they can do the self-test and send it back in. And this actually detects the cause of cervical cancer, the human papillomavirus. And the human papillomavirus, there are certain variants that are at high risk for cervical cancer. They're the cause for cervical cancer. So if they've been ruled out, then the risk for cervical cancer is lower. And if these results are negative, generally, women may be told that they could do another test in 5 years rather than 3 years. So this is some information if you'd like to learn more about the cervical screening program. But the BC Cancer Agency has been notifying all eligible women. But if you're over 25 and have not been up to date with your Pap smears, contact your family doctor, or you can contact the primary HPV screening hotline here, or with that link to Healthcare BC. So diabetes is a common condition, often hereditary, it's type 2 diabetes. So the usual screen, there's 3 types of tests to screen for it. The fasting glucose, the 2-hour glucose tolerance test, but there's also the hemoglobin A1C, which is a simple non-fasting blood test that's done at the regular Life Lab or at the hospital lab. So in the past, we used to consider most people over 40 with or without family history probably should do a screening test for diabetes at least 1 or 2 years. Current guidelines are those at high risk according to guidelines, and there's a risk calculator you can look up online, look up CAN-RISK, and it can tell you your risk for diabetes. And if you're at high risk, it should be done every 3 to 5 years, and every year if you're very high risk. As a general rule of thumb, if you're over 40, you haven't had the test done, talk to your family doctor about if you should be doing a screen for diabetes. If you have family history of a first-degree relative, like a sibling, a child, or a parent with diabetes, then you are at increased risk. So, and you probably should be screened. And the screening mammogram is recommended for all women starting at age 50. But there's controversy. I usually recommend my patients to start at age 40 because there are some more aggressive breast cancers that can appear at a younger age. But in general, a woman's risk for breast cancer increases as she ages. So even if a woman is past age 70, I may recommend a mammogram if she remains in very good health and has a good life expectancy, is likely to live another 10 years, then we probably would want to detect a breast cancer early before the woman has symptoms. So if you're over age 70 and in good health, you may be eligible to continue the screening mammograms. The screening mammogram report is sent to the family doctor as well as to the individual patient. And it also will give the breast density, a rating from A to D, with D being very dense breast. because the screening mammogram is less sensitive for detecting breast cancers with high densities. And in those cases, there are other tests that could be done as a supplement, such as an ultrasound. So if you get a report with, says BI-RADS or breast density D, then speak to your doctor about additional testing that we can do to screen for breast cancer. The screen for colon cancer in BC is the FIT. So that's checking for blood coming from the large intestine. So it's actually that it's a very, very small amount of poop that you need. So it's not that onerous to do. And this should be done every 2 years. The Cancer Agency has set up a screening program as well to send these kits to people that are over 50 if they haven't done it in the last 2 years. An alternative in some provinces, a colonoscopy done every 10 years, but because of access in BC, you'd have to pay privately to get that done unless you had additional risk factors like a previous polyp, or if you had symptoms like a change in your bowel habits, rectal bleeding, blood on the toilet paper over a certain age, or a family history of colon cancer. As I mentioned with screening tests, people with symptoms should not be doing the screening test. They should go straight to their doctor and see if they need to do a colonoscopy. And if you have family history, you should be doing a colonoscopy every 5 years as a regular family-specific screen. So screening for prostate cancer, the traditional exam is the digital rectal exam. And as the picture above indicates, it's not a high-tech digital exam. The digit refers to the doctor's finger in the glove. And we're usually using another finger, that the longer finger the doctor has, so it's a more sensitive test for the doctor to detect any abnormality with the size or shape of the prostate. There is another test that could be done as screening, but is not covered by the medical services plan. It's called the PSA, prostate-specific antigen blood test. And it's not recommended for everyone as a screening test because it may detect an abnormality that will not actually affect the health of the individual. If a man is in his 90s and has a PSA and is abnormal, it could be from an enlarged prostate. It could be from an early prostate cancer. So it's not recommended for every man because the patient may not actually have any symptoms of prostate cancer in their lifetime if it's detected and if you have a shorter life expectancy. So all men over 50 should speak to their family doctor about how they should screen for prostate cancer. Most of my patients are willing to do the blood test, particularly if they have family history, and they may want to screen at an earlier age than 50 with a strong family history. The other important thing, if you don't have a family doctor, you should be aware of symptoms to watch out for. And even if you do have a family doctor, I've done a presentation with Leona called Making Sense of Symptoms and Screening Tests, where we go over through these screening tests, but also talk about the different symptoms that we used to review with patients when physical exams were more common. But nowadays, physical exams are not part of what's covered by MSP, except with certain conditions like diabetes or other chronic conditions, where we can justify that to the medical services plan. So these questions that I go over are kind of reviewing symptoms that could indicate a problem that will require medical attention. So do look at our Burnaby Division website under Empowering Patients, take a look at my presentation and the list of symptoms to watch out for, and to ensure that you get medical attention and see a doctor if you have those symptoms. And finally, what is health? So is health just the absence of disease or the treatment or a cure of disease? I think of health as the optimal balance of the important areas of your life based on what you value and where you find the most meaning. And I think we all have a positive potential, and it's our purpose in life to achieve our positive potential. It's your gift to the world and your gift to your community and to yourself. And we are obligated to help others achieve their potential. And that's why Leona and I and the Burnaby Division of Family Practice do what we do to help you achieve your personal potential. That balance of all the important areas of your life, your social life, your family life, your financial and physical well-being, the health of your mind and your body, your emotions, and living in a place that you feel you belong. So I'd like you all to imagine achieving your positive potential. That's me with my dad, who remains active and living his positive potential at age 94. So please share anything you found valuable today with your loved ones, with your neighbors, and have those lists of those important things you should know about your medical history, those key questions the doctor should answer for you, so that you're an informed, empowered individual patient. And here's a bunch of my favorite patients on our annual box with your docs, and my family in the bottom corner, including my dad and my 2 sons. My daughter's not in that picture, but my sister and brother-in-law are as well. And remember, at least in my office, we think of you as a friend and a family member. So we want you to have the best care and the best life. And remember, healthcare is self-care, and we're here to support you in the best care.
That's
So
great.
I'm gonna stop my share just in case anyone has any questions.
Great.
about-
Yeah, thank you. That was so informative. I always learn something new when I listen to your talks. I find it very inspirational. So I had a really lovely note here from Masood, one of my colleagues. So Dr. Wong, you can read it in the chat. He did have a question about, he just said, which do you believe carries the most weight as far as your being an overall healthy person? Physical health, mental health, social connections, or society?
I think it's a healthy balance of all of it together.
Yeah.
Because we recognize in medicine the social determinants of health, that we all need a sense of belonging and connection with people close to us. We need healthy relationships. We need that perfect balance. That's why I show that little mandala that I designed. I could bring it back again, but that's what I used in early practice. I would put that in a place to meditate on every day. In the center was my calling. And then all those little spheres around those colored circles were the different areas of my life. And each of them I had particular goals. Like for my family, goals would be to have a good connection with every member of my family and a harmonious house and household. And socially, that I'd have a good group of friends that I can support and who support me. And I want work that's really meaningful, but I also want to have fun with creativity and recreation. So balancing that inner and the outer and your personal, individual, introspective life and inner life with your connections with other people.
Right, right. But we have to make a meaningful, we have to actually take that initiative to plan those things out. And you're always very mindful in how you plan life. So thank you. The other question again from Masood is, if community care is as important as acute care, do we have sufficient financial resources allocated to community care in Canada, both in terms of providers and beneficiaries? Do you have thoughts?
I it's hard to say we need both. I think if we did a better job in educating and supporting the public in healthy lifestyles,
Right.
catching conditions early, because we have these screening tests and we know they have a huge impact, but it's actually the minority of people that are up to date in all their screening tests. And a lot of people do their best with eating a healthy diet, but there's a lot of limitations as well because of a lot of confusing information. Why we came up with this Empowering Patients program is most of the health information that people get from the news, from the internet, from television is sensationalized or biased or someone trying to sell you something. Like you can't
Right.
even trust Dr. Oz because he's trying to sell you something. And
He's a
then,
politician now.
yeah, and of course, the things they talk about are only the sensational things in the news and not necessarily what's relevant to your personal health. I think if we invested more money in health education in our schools, invested more into emotional well-being, like learning the skills of mindfulness and recognizing uh, conditions early, psychological and medical conditions early, then we could save a lot of money in the community, catching things early, living a healthy lifestyle. So I think if we invested in a different way, we obviously need more money, but it's more than just investing in healthcare providers or hospitals or facilities. It's changing the whole culture, that we're more of a health-oriented culture, like those blue zone countries where, like in Okinawa, like young girls, they form a community of friends that are friends for life. And that is a big contributor to their physical and emotional and social well-being, is that they have this team of friends that are not family, but are just like family, just so they always feel supported and have that sense of connection. So
Right.
we need, especially in such a diverse city like Burnaby, pretty well all of BC, that people can be quite isolated, even if they're in an apartment building in a condo with 400 other people. They don't get to know all those people and don't feel connected with the people just next door to them. So we all need that sense of belonging, know that we are part of this greater community, that we have lots to contribute, and acknowledging one another and connecting the way that we're meant to be connected.
Right. That's very powerful. I'm very fortunate. I have a wonderful neighbor who bakes for me. I take care of her cat and then she bakes for me. So it's lovely to have that in as a neighbor. Craig has asked, do you think that ER doctors who generally do not know their patients ever ask what is the worst a symptom could be or looking for what most obvious?
I think most emergency doctors do. In fact, I was just on a continuing medical education lecture by an emergency doctor from Ontario, and uh, and he gave an excellent lecture on cognitive biases.
Mm,
How how physicians, actually we all have cognitive biases, how we kind of get in a certain line of thinking, and there's fallacies in our thinking. But he talked about ways we can mitigate this, and one question he asked himself, is this going to kill the patient? Is this something that could kill the patient? Could this be fatal? Could this be serious? I know a lot of emerge doctors think upon that line as well.
Great. Thank you. Alice has said, my family doctor has referred me to do some blood tests and screening. Can I ask my family doctor to print a copy of the test result for my own record?
Yes, you can, but actually there's some great apps like the BC Healthcare app that you can get onto your phone or computer. So it actually lists all your lab results, lists all your medications, lists all your immunizations. So you may want to check. If you don't feel tech savvy, just ask uh, a younger relative or a kid to show you how
Yeah.
to access that. But it's really handy. It's really helpful. You could ask the family doctor; they could print it out for you too.
Right. It is
Yeah, or we
nice to
often
have the
email.
portal.
Yeah, yeah. If patients don't have access to the portal, we often send copies of the reports and results to them as well.
Right. Okay, great. So Masood just wants to say he's reading your recommended book, Mind Over Motion, and he's loving it. So good recommendation. That's it. Let me just make sure I have captured all of our questions. Oh, Marcella wants to know, can family doctors improve ER waiting time?
Well, one way we're doing it was with our urgent primary care
Thank
centers,
you.
the UPCCs.
Mm-hmm.
We have these great UPCCs that are staffed by a combination of Burnaby family doctors, community family doctors, with excellent allied healthcare staff from Fraser Health. They have psychologists, social workers, great nurses, and medical office assistants. So it's a great team, and they treat at a level a bit higher than a walk-in clinic, but a step down from the emergency. And of course, family doctors can help by everyone being family doctors so that we can accept more patients and do a lot of the preventive healthcare and take the pressure off the emergency.
Right. Yeah, good point. We're very fortunate to have two UPCCs in Burnaby, so very, very fortunate. And that's it for all the questions. My one last little thought is just to remind you, when I close down the session, when we're finished, there will be a quick evaluation. If you wouldn't mind taking a moment to fill it out. Dr. Wong and I read all of your comments, all your recommendations. It'll give you a chance to sign up to receive notifications for upcoming talks. We have I think we have 7 more scheduled for over the next few months. So please take a second to answer those questions if you wouldn't mind. But that's all the housekeeping I have.
Okay, thanks, Leona, and thank you, all of you, for joining us this evening. And please share any information you found useful with your friends and your family.
Yes, thank you. Excellent. Well, we're giving you 14 minutes of your life back. Awesome. Thank you so much, everyone. Enjoy your evening.
Have a
Take
good
care.
night.
Bye-bye.